I am going to talk about the chemoimmunotherapy in advanced urothelial bladder cancer. With the upfront, we are treating the patient with the chemotherapy and immunotherapy. So I'm just asking for the patient for the metastatic or advanced stage bladder cancer or urothelial cancer, in the real world, hardly they survive for a year or 12 months, 14. But in a trials, you found definitely 30 months. But in a real practice, we all know it is very difficult to treat bladder cancer patients. In the previous, they got some radical surgery. In the surgery, some of patient lost their one kidney and some injuries. And after that, they got a metastasis. So they hardly survive around 12 to 14 months. And after that, we seen in the mainly in the previous the cisplatin based trial, they hardly PFS is around 5 months or 6 months with the cisplatin, 6 to 8 months. And without cisplatin, there is no good drug which provide a significant PFS. You can say that improve the OS and all. So cisplatin is the only answer. Cisplatin based treatment is the only answer for the bladder cancer. So we know, and I am asking one more thing: how much patient we are easily delivered second line treatment? Because in the as we see after first line, median age of presentation of the bladder cancer is around 60 to 65 patients. In an Indian scenario, most of patients are some kind of comorbidities. So very difficult to a clinician for a second line treatment for a bladder cancer, especially those who are progress on a platinum. So for a clinician, we want our first it should be a perfected. So we talk about immunotherapies. We tried multiple immunotherapy trials with atezolizumab, durvalumab, but definitely this is very challenging in blender to demonstrate the immunotherapy benefit. So somehow it is called as a bladder is one of the most immunogenic cancer, but we didn't found any positive result from the immunotherapy trials. So somewhere in the research in future, we found some molecular classification that will describe these things. So definitely we want some treatment that hit in the first line. So I just on a funny note, I want to say this is a debate between avelumab versus nivolumab. Nivolumab को मैं अपना lumab बोल रहा हूँ because we had a kind of data, we have a low dose nivolumab data we established in the head and neck, and I want to ask a clinician which immunotherapy you give frequently. So everyone agree with the nivolumab. So definitely forward कैसे करते हैं? Okay. So we all know this is the I already discussed. So approximately 20 first line I already discussed this. So yeah, definitely the PFS and OS is shorter with the first line, and after that the difficult to deliver the second line. Or this is the evolution of the systemic therapy, as we all know, with the starting with the taxanes and gemcitabine, after that the platins, and later on the immunotherapy drugs. So till now we have an option for the platinum eligible patients, DDMBEC followed by the avelumab maintenance by the guidelines, GEMS followed by the avelumab maintenance, pembrolizumab and enfortumab is the for the cisplatin ineligible patients. This is a summary of the chemo trials that we are already discussed. What the PFS and what the rates we found. One more important thing I want to discuss the response rates. So definitely the response rate you see in the CR rates with the cisplatin treatment is around 11 to 10 to 20%. So this is avelumab Javelin trial is the design. So we all the sir already discussed this about this. The OS and PFS is already discussed about the Javelin trials. So yes, for the same PFS you can see it. I want to discuss this subgroup trial also. You can see in this subgroup analysis the population that belong to the Australian region. This is a hazard ratio that is not favored in the avelumab maintenance. So somehow we have to ask for that some molecular classification that definitely describe the immunotherapy needs. So I want to discuss one more important part is the response rate. So when you discuss the avelumab plus BSC arm, there's a complete response rate is around only 6% in the patients. Partial response is around 3.7% patient. Stable disease around 12% patient. And the progressive disease around 37% patients. So the CR rates is very low with the avelumab and the BSC avelumab arm compared to the when we discuss the technique, then we found in different answers. And I want one more thing in this trial. You can see the graph A, B, C, D, E, N. A, B is that for the cisplatin and carboplatin OS arm. In the C, D, E, for the patient, C is the patient, you can see those who are a CR. D curve for the patient, those who have a PR. And E is the curve for those who have stable disease. So you can clearly see in this graph that those who have a partial response after GEMSIS, they done a well separation of the curve till 36 months. But when you see the graph on the CR and stable disease patient, you see there is not a well separation of the curve. So somehow the patient there's already achieved some good CR, then definitely this is the main part is the chemotherapy that going then leading the that survival. So, and second part is the stable disease. So, stable disease patient more or less almost same in 36 months. So, they are same in the survival. So, definitely those who are partial response had a good OS benefit with the maintenance. But when we discuss the long term about the stable disease patient and CR, so that definitely questionable. Now I'm talking about the patient, those who have those who are on a Javelin blood 100 trial, and you can see in this chart, those who receive subsequent therapy or those who not receive subsequent therapy is around 185 patients receive subsequent therapy, 120 not receive subsequent therapy. The reason for discontinuation is mostly the progressive disease. Is around 158 patients, those who are abilimum armed, receive subsequent therapy, have a progressive disease. For adverse is around 15 withdrawal and consent, rest are the mentioned. So the main part for the discontinuation of the treatment is the progressive disease. So this is the most important part. Those patients who didn't receive immunotherapy due to progressive disease, so definitely we have to talk about the immunotherapy from upfront. Now, what the patient receive after the progression? So the all patient who receive PD-11, around 52% patient, it's around 11% patient receive PD-L1 or PD-1 inhibitors, and rest are receive FGFR and other drugs. And most common, most patient who discontinue study therapy because of PD is around 200 patients, and received PD-1 inhibitor around 12% patient. So definitely patient receives immunotherapy, but there's no good number of the immunotherapy they receive. This is already I discussed, but this is that the data of the abilimum arm definitely showing benefit of the starting abilimum immediately of the first line is instead of the waiting of disease pattern. So abilimum maintenance is the first evidence that support the immunotherapy in the bladder cancers. So now I move to the my part is Checkmate 901 trials need to be discussed in contrast to the bladder 100 trial and EV302. The paradigm, the first line therapy for metastatic urothelial cancer has evolved over the past few years based on the result of Javelin 100 trial. The administration of abilimumab as a switch following stable or prosperous disease with 4 to 6 cycle platinum-based therapy. The trial OS is good, around 38 versus 15 months. However, the repeated observation that only approximately 50% receive maintenance or second-line therapy in the real world suggested we need a more effective first-line therapy, and for vedolizumab plus pembrolizumab and GEMSIS nivo is the answer for that. Nevertheless, cisplatin ineligible patient who are clearer, who are a poor performance status, the Javelin is the more feasible for that. So prior to the presentation of the EV302 or keynote with A39, no novel agent has improved OS concurrently to added platinum-based chemotherapy in the first-line treatment for the advanced bladder cancer. Although abilimumab has been approved in the sequential maintenance patient without evidence of disease progression with platinum-based therapy. So this is the remains as unmet clinical need in the first-line setting for the treatment that improve the patient's outcome. So this is the trial for the immunotherapy. Nile data is awaiting. Vigor 130 and keynote is a negative trial. Checkmate 109 arm that Nivo GC versus GC is the positive. And the second part is the enfortumab vedotin plus pembrolizumab, that is a positive. So those are the trials. This is approved. This is found positive result in the first line. So this is the now I move to this trial some qualities. So phase 3 trial, multinational open label randomized trial. Inclusion criteria is the same as a most of trials. More than 18 unresected advanced stage. At least main part is the cisplatin eligible patient is considered only, and with the good PS. Same with the exclusion criteria. This is the study design of this study. Nivolumab 360 milligram, GEM 1 gram, day 1, day 8, and cisplatin with the 70 milligram up to 6 cycle, followed by the nivolumab maintenance until PD or toxicity or 2 year. And the primary endpoint is the OS and PFS, both are considered as a co-primary endpoints. So this is the population is perfect for that. Nivolumab dose is considered for a 3-weekly dose. Comparison with the GC arm, outcomes is good. Median OS around 27 with the Nivo GC. versus 18 months in the GC arm with the hazard ratio of 0.78. Median PFS is around 7.9 versus 7.6 months with the good hazard ratio and with the p-value. CR rates you can see in this trial is around 21%. The GC plus Nivo arm versus GC arm only, and the median time of follow-up with this study is around 33 months. So number of patients included is around 608 patients. Group you all know. The treatment completion rates in the test arm is around 70%, and the alone now is a 54%. And they substitute the carboplatin for the patient, those who develop toxicity over the cisplatin. And the most common reason of discontinuation in the both group is TD only. The checkmate baseline characteristics is well matched, and you can see the number of Asian population included in this trial is around 24%. So you can see the overall survival at a 1 year is around 70% versus 62%, 2 year around 46 versus 40%, and the median PFS you can see what is around 1 year is 34 versus 21, and 2 year PFS in this trial is around 23 versus 9.6 months. So there definitely 2 year PFS is good with the GC Nivo arm. So this is the overall survival. So we already discussed about the 2 year and 1 year survival where curve are well separated till 36 months. This is the subgroup analysis. You can see the all group is favor the mainly Chemo GC arm with the well-matched conditions. This is the PFS. Definitely, this is 9.6 versus 23 months is the 2 year PFS. And the PFS in subgroup that also favor in the Nivo GC is the better compared to the GC alone. And now is the best part is the response rate. You can see in this trial, chart, the CR rate with the Nivo GC arm is around 21% compared to the GC arm is around 11% only. So definitely the median that response rate is good with the Nivo GC. That is the objective response rate. We already discussed the one. That good part is this trial is around this response rate at a 1 year is around 29 versus the 46%. At 2 years around 12 versus 35%. And the safety, the most common toxicities, toxicity almost well matched in the both groups. The most common toxicity is neutropenia and anemia only. And patient is having acceptable immunotherapy related toxicities also. So definitely we can plan for this treatment. And now I talk about the quality of life in the both arms. So you can see that there is no deterioration in any arm. So definitely quality of life is same for the both arm. So my conclusion for that, nivolumab plus Gemcis demonstrates statistically significant and clinically meaningful improvement in the OS and PFS versus Gemcis alone in the first-line treatment of advanced urothelial cancers. Objective response rate and complete response rate is very notably higher with the Nivo arm. The complete response rate almost double when compared with the alone GC arm, chemotherapy arm. And I discuss about the SWOT analysis of this trial. So that strength is improved OS, good CR rates, and weakness of this arm is only single arm that compare. There is no between compare any other immunotherapy arm, and the opportunities definitely we have to need some longer follow up for this because this is published in ESMO 2023. So we need some more follow up time. So after that, and definitely low dose immunotherapy we can expect from the cancer next month. Next in no time. So definitely treat nothing to be treated. That cost is only treat for our Indian population. So my take home message for segment 901 trial is improve in the both co-primary OS and PFS with the GC alone. Response rate are quite good. CR rate are definitely high with the Nivo GC arm, and the Nivo GC arm is a regime that has a definite 6 cycle of Nivo plus GC followed by the until progression or 2 year the nivolumab. So definitely we want to hit the first hit about it should be our perfect hit. So nivolumab I choose with the GC. Thank you.
Thank you, Dr. Abhishek.
Can I have some comments?
Yes, Dr. Amol, sir. You are
So basically, the crux of the matter when you are comparing Javelin 100 versus Checkmate 901 Nivo arm is that whether both have given maintenance IO. The question is whether the additional 6 cycles of IO therapy, which is given along with the first 6 cycles of chemo, are going to make a difference. That is the only difference if you leave the debate between nivolumab versus avelumab. I'll come to that. Now, there are 2 points that our colleague has discussed. Response rates. Let us understand, in Javelin 100, the patients were given immunotherapy after those who are receiving good response. That means the baseline, they were responding well, and in addition, you want to improve by giving avelumab. So the increment in the improvement is not going to be as shown in Checkmate 901 when you are starting from the baseline metastatic. So response rates of Javelin 100 cannot be compared with the response rates of 901 because the starting point is different. That is the first thing. Second thing, by giving additional 6 cycles of immunotherapy, that is Nivo in this case, by giving around 12 lakhs rupees treatment with an additional toxicity, how much benefit of PFS you are getting is 9 days. I agree that 9 days is statistically significant, but it is only 9 days. If you see the control arm of the Checkmate 901, the PFS is still around median is 7.6 months. So are we going to overtreat these patients by giving additional 6 cycles of IO? I feel yes, according to me. And the another point he said that nivolumab is apna mumab. I agree to that. And what I will ideally like to do is give Gemsys upfront. Those who are responding, which I ask them to give low dose Nivo as a maintenance. And this is what ideally I will like to do rather than giving avelumab. I'm not in favor of avelumab also. And the last thing is that what if suppose somebody decides to do EV Pembro upfront, which is not, of course, it is an ADC plus IO, is not a part of this debate. But by giving EV Pembro upfront, you may get upfront a 6. But what is the point? There is nobody there left to play the remaining overs. Who is going to play once the first batsman is out? There is nobody there unless and until a new drug comes up, the second ADC or something comes up to back up the EV Pembro, the overall run will be the same. Even if you पहले बॉल पे छक्का मारने के बाद में कोई बैटिंग करने के लिए नहीं है, तो टोटल उतना ही बनेगा जितना बाकी लोग एक एक दो रन निकाल के बना रहे हैं. That is what my point is. So this is what I want to suggest, that probably the solution is to give Gemsys, see who are responding well, and then probably give maintenance, which may be whichever IO. And I also will prefer Nivo, and especially low dose Nivo. Now,
so how many of you actually practice giving sequential therapy right now? The crowd. How many are not practicing? Actually, this data came much before, and the data is already mature. So, I think we will directly comments from Kumar sir.
One trick question for Amol. Amol,
yes,
तो तेंदुलकर से तो कभी ओपनिंग करानी नहीं चाहिए.
नहीं सर, करानी चाहिए, लेकिन तेंदुलकर के बाद आपको अच्छे प्लेयर्स चाहिए थे. धोनी चाहिए. अगर धोनी रहेगा तो ही वर्ल्ड कप जीतोगे. अकेला तेंदुलकर कहाँ वर्ल्ड कप जीता सर? धोनी चाहिए पीछे.
That is a rhetoric question. So coming to science part, the science part is the most important part of our debate is, did I learn something while listening to people or not? And I did. And many times I hear debate where people talk both sides. That was not the case. And that's the best part of our debate. And I enjoyed it. We know that now we have 2 options. Third options will be soon there. Looks like that may come in India. Not how many people can afford. That's a separate question which will come. And more is always good. We hope that increases competition and that allows more benefit to our patient. Otherwise, debate was good and I absolutely enjoyed. Thank you. Thank you both.
Thank you, sir.
Any additional comments, Amit Joshi sir, regarding this approach? Because definitely the answer is not clear, but what should be the outcome? I think another point which in favor of more will be the longevity, the data which is available. And nivolumab has just come up on 2 years follow, but if you see the Javelin 100, it's I think 3 years or 4 years. So the consistency that this approach works as a maintenance more than the early. That is one additional point in your favor. But this point that in a day-to-day practice, how many patients are able to that in a bladder cancer around if we give the initial chemotherapy, 50, 60 or 70% patient will not be able to receive any sort of therapy later on because their deteriorates and they will not be considered for any therapy. From that point of view, putting immunotherapy early maybe so I think that is the point in his favor that more than 50% patient will not be able to receive anything. So why to keep at the end when the case deteriorates and then poor care immunotherapy will not work.
So I think both are right. Both have its own merits and demerits. But as Kumar is saying that EV Pembro is maybe so neither you and nor he. So at some point of time, both will change and next debate and whether EV Pembro will be. And the way the data looks so promising, if the cost comes down, there is no doubt in my mind that the EV Pembro will be the clear winner in even. And the way it is coming into the new adjuvant also, I think things will change very well. But yeah, the cost is a very important factor. So, like